Okay. Morning. I'm Madonna. I'm one of the fourth years. I think probably everyone here knows me by now. I'm going to be kicking off the senior lectures, and this kind of feels like an awkward goodbye because I'm like, goodbye, but I'll be here for 4 more months. But I wanted to talk about sign outs. I think there's so much to learn from sign outs. It's something that we do every day in the emergency room, and we're going to be doing it for the rest of our careers. And it's such a vulnerable time. And I have a love-hate relationship with sign outs. I love them because they're challenging, and I also really dislike them sometimes because they're really challenging. Okay. So just kind of the layout of what I'm going to talk about for the next 30 minutes. So to talk about the challenges about signing out, how to improve giving the sign out, how to improve actually receiving the sign out. After you round, what do you do with all the patients that you just got signed out? And then I'm going to give a few patient examples of patients that I got signed out and just kind of how I manage them. So just to kind of set the stage, this was my first shift in the ER as a senior. Overnight in the pod, I came in, I got 8 signups. 6 of them were pending some kind of a CAT scan. There are 10 patients who are waiting to be seen. I had 1 medicine rotator with me for the night. And then on rounds, I noticed there's a hypotensive patient whose 80s over 50s on the monitor, has not been seen yet, doesn't have an IV. The nurse tells me it's a dialysis patient, it's gonna be a hard stick, there's nothing ordered for him. So we finish rounds, and I'm thinking, who do I go see first? Off the bat, I already have 8 patients that I'm responsible for. I have a sick person here. There's 10 people waiting to be seen over like 5 hours. So at the end of this 30 minutes, I'll give you a few tips on and like who you should see first and how that depends on the room and the resources that you have. Okay. Oh, it skipped a slide. Okay. So let's kick it up a notch and let's advance a few years where you're the attending. And this is actually a real life example of last month when I was in Hawaii at the community hospital there for an elective rotation. So you're the single coverage attending there at a community hospital. You have no services there. You get your sign out of, your 5+ patients, particularly of one sign out, a patient who has a history of CAD. They're coming in with a lower GI bleed. They've been here in our ER for 3 days being managed by the ER doctors because no hospital has services yet to accept the transfer. Every hospital on the island is full. So you get your sign-outs and immediately you get a cardiac arrest that comes in. You go run that code on your own. There's nobody else to help you. And the nurse comes in and she tells you, hey, that patient with the GI bleed is bleeding again. Now they have chest pain. I did an EKG. Here's the EKG. You look at it, there's ST depressions. So you have no MICU, you have no GI, you have no cardiology, you have red blood cells, but you don't have platelets or really anything else. What do you do? And this is just kind of highlighting the vulnerable period of time for these patients who are getting signed out to sign out to sign out, and that risk of having, maybe a little less care or attention because sometimes they're easily forgotten. But also it's supposed to highlight, this is your period of time to ask questions and clarify. And what was the last hemoglobin for this patient? What was their last set of vitals? And this might be a patient that you go see right away, right after rounds, before you see any new patients, so that when they decompensate later in your shift, you already kind of have a plan of what you're going to do. I came across this quote when I was making this lecture. It says, sign out is the most dangerous procedure in the emergency department. I think this should just kind of stick in the back of your head for the next like 30 minutes, but also just throughout your career. The NIH estimates about 80% of medical errors are actually due to miscommunication during handoff time period. And in 2016, medical errors were the 3rd leading cause of death after cancer and heart disease. So this is a really important topic to talk about. Sign-outs happen 2-3 times a day on each side of the pod. Sometimes a patient gets signed out multiple times. There's so much opportunity for things to go wrong. And more importantly, a lot of these things can be easily preventable. So what are the consequences? So patients can have increased lengths of stay in the hospital. There can be duplicate testing or increased testing in general. Patient dissatisfaction. Patients can lose trust in the providers. There can be errors in the diagnosis, errors in prescribing medications, and in follow-up. And what kind of goes wrong? Most commonly, it's omission of information. So when you're giving the HPI, maybe you're forgetting important details. And then the second most common reason is just lack of a contingency plan. All right, so the next few slides, I'm going to talk about the challenges around the sign out period. And as you'll see, a lot of these actually aren't something that we can really change. So think about our ER, right? Is our ER quiet? Is it spacious? Definitely not. There's alarms going off, phones are ringing, patients are screaming, crying, even just physically getting through the hallways. You have to dodge people, stretchers. There's always like a computer on wheels in your way. It can be really hard to give sign out when all that stuff is going on. You can't even make like a full circle for everyone who's supposed to be on route. Think about all the interruptions. Attendings are getting handed an EKG every 5 minutes. Consultants are walking by trying to give their recommendations. Family members are asking for updates. Patients are asking for food. And then think about the time as well. It's the end of someone's shift. They just worked an 8, 10, 12-hour shift. They're tired. They want to go. It's the beginning of your shift. You want to start seeing patients. If this rounds takes you 45 minutes out of an 8-hour shift, that's already a pretty significant chunk of time. Think about the patient. So how much insight do they have to their illness and their medical education in general? And what was their relationship with the previous provider? If they didn't have a good relationship with the first person, they might not have a good relationship with you when you're being signed up. Um, a lack of a standardized approach. So we're getting people from all different medical institutions. The way people sign out is different depending on how they've learned it. So there's different style, different content, length. There's different expectations in terms of like complexity, simplicity, the content types of patients. So signing out a patient pending an X-ray is going to be very different from signing out a patient who has CAD with a GI bleed. It has to be a balance between completeness, but also conciseness. And then lastly, bias. Bias, I think, is the most important thing to talk about. I think it's the biggest area for change, but it's also the hardest thing to improve on. We'll never get rid of bias. Everyone has it just by the fact of us being human. But it's something to keep in the back of our mind. I think as long as we acknowledge it and try to improve upon it, it's something that can potentially change. You're getting painted this picture of a patient, and that picture is going to stay with you even when you're seeing the patient. But it's really important to come to your own, assess your patient, examine them, come to your own conclusions, your own assessments. Maybe that means you change the plan. Okay, so I have 10 tips on how to give sign-outs. Some of them were just from personal experience, and some of them are from some resources that I found online. So start with the diagnosis if you know it. This isn't a mystery game. If you have a CT scan that shows appendicitis, you can lead with this patient has CT proven appendicitis, they're pending surgery, and then go into the HPI. Be ready to sign out when you can. So the ER is really busy, things are changing all the time, patients are coming in or leaving. So if that means signing out right at 3, you should be ready to sign out right at 3. Mention who's the sickest patient in the room, especially important in like really busy rooms, or when you're signing out like 10 patients. It's always a good idea to say, hey, I know you just got 10 patients, but just keep a close eye on this patient, like their finger sticks have been running low, just so that when, all that information overload is happening, that person coming in can still remember that one person who really needs extra attention. Cut down on your amount of words. I think this is probably one of the best things that we can work on. So the more that you talk about, the easier it is to kind of get away from the main point of things. Mention exact values. It's like a white count of 28 is very different from a white count of 13. So instead of just saying leukocytosis, you should say what the exact number is. Mention special things about the patient. So does the patient not speak English? Are they a Jehovah's Witness? Do they have multiple antibiotic allergies that are going to make their care a little bit more complicated? These are good things to mention to the next person. Have an anticipated disposition or contingency plan. Be honest, if you don't know if the patient's going to be admitted or discharged, that's okay. That's normal, that happens. But then explain, what information are we waiting on? And then even more importantly, have a contingency plan. It's like an if-then statement. So for example, if the CAT scan is negative, they can go home. Or if the CAT scan is negative, consider a transvaginal because I think something really is happening in this patient. Try to finish your necessary work. So obviously to the best of your ability, try to wrap up as much as you can for your patients. At minimum, that's like writing the IPN, that's putting in all their orders, that's calling a consultant if needed, and also, of course, completing the full physical exam. So you wouldn't sign out like a heart and lung exam, so you really shouldn't be signing out like pelvic or DREs. Of course, there are certain circumstances where that's maybe not possible, but as best as you can, try to wrap up everything for your patient. Do not forget about any patients. So if a patient's just sitting there waiting for discharge, that's still a patient who's in your ear that you should know about. So even just like a one-liner about these patients is really helpful because when those patients are still there 4 hours later, or when you're rounding again, it's good to kind of have some idea about them. Um, Alert your patients when you'll be transitioning their care. I don't think we really do this a lot, and it's, obviously not mandatory. But if you have the time, I think it's a really good idea to just sit down with your patient and say, like, so and so is taking over for me. I told them about your history. They're going to come in and probably ask you a few extra questions, just so that patient, feels like they're listened to, and that, they're expecting to see a new face next time, and they don't feel like it's a completely different person who doesn't know anything about them. Okay, and then I have 10 tips on how to take the sign out. So on the other side of things. So be present. I think this is easier said than done. But like, you're coming in for a 7 a.m. shift, you're thinking about how you want to get your coffee, and you're tired and thinking about your weekend plans. Try to get all of that out of your mind. And the most active listening you can do, the better and the easier it will be to recall things about these sign-outs later. Write things down. Especially when you're getting like multiple sign-outs, it's good to just write down the basics, like their past medical history, what did their lab show, or like important vital signs. That way you don't have to just memorize off the top of your head like 10 different people's past medical history. Ask questions. This really is your time to clarify things about the patient. Directly ask, like, did you consider PE in your workup? And if not, then why not? Try not to judge the team. They just worked 8, 10, 12 hours. If anything, you're a new pair of eyes, your second provider that's seeing the patient. That's almost always going to be a good thing. There's something else that you can offer. If it's maybe broadening the differential or providing more reassurance to the patient, that's something that you can bring. We kind of touched on already, but try to avoid bias. Um, so, for example, if you're signed out a patient with flank pain and they're pending a CAT scan to rule out a kidney stone and the CAT scan doesn't show anything, keep thinking, like, this could be just MSK pain, but is it a PE or pneumonia? Try not to just anchor yourself on what the previous team tells you. Really, really important, examine all of your signups. You are responsible now for these patients, not the previous team, it's you. So it's really important that you assess these patients yourself, especially on patients who come in with like skin and soft tissue infections or wounds. We'll touch base on a patient example later, but like, multiple different providers seeing the same wound are going to describe it all in very different terms, and they're going to have different plans for the patient. Some people would want to discharge them, some people would want to obs them. You might want to change your plan based on how you look at this wound. Reassess and repeat the vitals of the sign-outs. That's also really important. A lot of times people, start to develop fevers while they're here. Their illness is really starting to present themselves like a few hours into the ED course, or are they decompensating? Know who's the sickest in the room. So that kind of goes along with, telling that person. But if that happens to slip through on the previous sign out, ask who's the sickest person in the room. Keep your eyes on them. Know the room. So I think we do a pretty good job of that. But on rounds, just kind of patients like a one liner, like what are they admitted for? Try to know code status. So if somebody's DNR or DNI in your room, you should at least keep that in the back of your mind. And then really importantly, to document your sign outs. So you're not writing the IPN, but you are seeing these people. So you should at least document an exam, their vital signs, and kind of like what you're thinking about, especially if anything changes, if they decompensate, if your plan changes, if they need to be brought to CCT. Okay, what are the red flags of signing out? So a sign out of a sign out of a sign out should always raise your antenna that something is going wrong. So do they need escalation of care? Are things being delayed? Is the exam completely changing? At minimum, it's telling you you need to go see this patient and reassess them and probably just confirm the history, because at this point it's been signed out so many times that information could be lost or changed. This is a big red flag for me. That's probably the first person that I would see if there's not a really sick person waiting, just to try to figure out what to do to intervene there. And then the other red flag, the patient sitting in front of you does not match the picture that's being told to you. For example, you're getting signed out, this patient came in for cough and they looked well, but you're looking at them and they're tripoding in front of you. That's not to say that the team before you missed anything. It's just to say that patients are dynamic and they change, and that might be someone to go see right away. Not only because their plan is going to change, but potentially they're sicker than you initially thought. Okay. And then how to handle signouts. So you finish your rounds. Now you have 10 patients right off the bat that have been signed out to you. What do you do? There's many different ways of handling this, and it's very variable. It depends on how sick these people are, how many sign-outs you have, how many people are waiting to be seen, how many other providers there are with you, what kind of resources you have. So I'll just kind of go through a few different techniques that you can use to handle your sign-outs. So the first example would be like see all of your sign-outs first. This works best if it's like a not busy shift, like if you're coming on a 7 to 3 shift and there's like one or two waiting to be seen, you can kind of just see everyone that's been signed out to you, lay your eyes on them, touch their belly, see if anything needs to be changed. Um, or conversely, that's if everyone sounds like they're really sick and you just need to go see them right away. Um, Another technique is to see your sign-outs when they're ready for disposition, meaning all the labs are back, all the CAT scans are back, everything's resulted. That's the best technique, I think, when it's a really busy shift. So when there's a lot of people that are waiting to be seen and you get a few sign-outs, you can go see patients who are waiting to be seen. And then when everything's back for those sign-outs, you can go and make sure everything's wrapped up and they're ready to be admitted or discharged. Or you can see patients in the priority of who is sick. This kind of is the general like idea of what you should be doing on most shifts. But this is probably more important for like the CCT area. So try to triage in your mind who is the sickest person, who has the airway issue or is hypotensive, and then go on and see everyone else, which is kind of what I did. If you think back to my first setting the stage, I saw that patient who was hypotensive first, and then I managed the rest of the waiting to be seen. Or you can see patients who are close to discharge first, just because it kind of like decreases your cognitive load. You can say, oh, okay, they're just waiting. They're low risk chest pain. They're just waiting on their troponin. Okay, I'll go see them really quickly, make sure that's fine. So when the trope is back, I can get them their papers and get them out of here. Or the other option is to see patients whose physical exam is a limiting factor. So I kind of touched base on it, but patients with like wounds or skin and soft tissue infections, right? Your plan might change depending on how you see this wound versus how the team before you saw the wound. So it might be a good idea to see those patients first because that plan might change. All right, so now I'm going to go into patient examples. So these are all examples of patients that have been signed out to me. This is not meant to be an M&M by any means. It's just meant to show you that patients are dynamic and illnesses present themselves within an ED course, maybe not initially, and just highlight the vulnerability of the sign out period. A lot of these cases are kind of oversimplified just in the interest of time. And I'm not really going to focus on the medical aspects, more so just like managing. Okay, so the first case, you have a 34-year-old. She has no past medical history. This is your sign up. 34-year-old with no past medical history. She has dysuria and vomiting for 3 days. Initially, she was febrile. She was tachycardic to 130s. On initial presentation, the team tells you she was oriented. Her exam was really just remarkable for CVA tenderness. Her labs show a white count of 15. Her UA is very positive. She got 2 liters of fluids, antibiotics, antipyretics, and just follow up the CAT scan. We're trying to see if she has pyelo or stone. So you get that sign out, and I go into the patient, and the CT shows pyelo, no stone. She's still tachycardic to 130s, but she's no longer febrile. She's awake. She looks well, like overall. So I give her 1 more liter of fluid. So now she's gotten 3 liters. Her heart rate's still 130. The EKG shows it's sinus. It's not AFib. So at that point, I'm like, maybe it's just tachycardia from sepsis, from an underlying infection. Do I need to investigate a little bit more? So I add on TFTs and I find out she's in thyroid storm. So I think there's a lot to learn from this case. I definitely will never forget it. Most importantly, always reassess the patient and repeat their vital signs. So had I not repeated and found her heart rate of the 130s, maybe I would have thought she looked well enough to go home and she would have decompensated at home. Or I didn't repeat the vitals and I call PIC to admit her. Maybe she doesn't look well. PIC sees that her heart rate's 130s and they yell at me. They add on TFTs and they find it later. Or she gets admitted and decompensates on the floor. Try to avoid diagnostic bias. So obviously the previous team, the thought is pyelo versus stone, which is a very reasonable first thing to think about in this patient. But when things aren't really aligning right, you kind of need to broaden your thought process and consider other things that are going on. And then also just keep these rare things in the back of your mind. Like if you're not thinking about thyroid, you're probably not going to be sending off the labs. All right, my second case. So you get signed out. A 60-year-old female comes in with generalized weakness, altered mental status. She didn't know she was febrile. She had some vomiting, but no other infectious symptoms. So initially, she was febrile to 101. The team tells you she's hypotensive. She's not fluid responsive. Her exam, she's actually mentating fine. Her neck is supple. There's no rash. Her lungs are clear. Belly isn't tender. She seems, kind of fatigued, but non-toxic appearing. Her labs show a white count of 20, a lactate of 4, her UA, her X-ray, her Cepheid are all negative. So you don't really have a source based off of the exam or the workup so far. So they tell you they gave vancomycin, they just put in a central line. She's on levofed, very low dose at 5. Now they're signing out just follow-up MICU recommendations, and we ordered a CAT scan to see if that's the source of infection. So I go and see the patient, and she tells me she has neck pain, throat pain, ear pain. She's just feeling pain kind of everywhere. I examine her. I agree she's still mentating fine. She looks kind of tired. Her lungs are clear. She doesn't have any leg swelling. But now I'm seeing these small areas of petechiae on her arms. Those are just kind of developing in the last few minutes. And I look at the levofed drip, and now it's at 20. So her pressure requirements are going up. So I add on Bezo. I call MICU to tell them, things are changing here. Maybe just, come down and reassess her. So I go back 15 minutes later because I'm thinking, she's probably one of the sickest patients in the room. And I see that the petechial rash has spread. Now it's purpura. It's on her trunk, her back, her extremities. So I brought in the antibiotics. I call MICU. Her CT eventually comes back. It's really nothing there. And we admit to MICU. And the next day, her cultures come back as Neisseria meningitidis. So I don't think anyone would have thought of Neisseria right off the bat in this patient. She actually was a stroke code when she first came in for altered mental status. Um, so just some learning points. Patients are dynamic, right? Their exam is going to change. Their illness may not clearly show itself until hours later in the course. And in this patient's case, we didn't even have a diagnosis until the next day. Like we didn't even know in the emergency room. Although by the end of the ED course, we kind of had our suspicion. But this is really important that you just reassess all of your sign-outs, examine them, especially the really, really sick ones. They're really dynamic and their status can change really quickly. All right, next example, you're on rounds at 7 and you get signed out. This patient in 7 hallway has been discharged. He has his papers. He just needs some encouragement. He came in for intox and now he's clinically sober. And the sign out is we'll call HP, we'll get him out here. So an hour later, the patient is still there. The bed sheets are over his head. So you go and talk to him. He actually seems kind of confused, like he doesn't really know like where he is or the year. So you pull the sheet off, look a little bit closer. There's no signs of trauma, but he can't really walk. Like he's unsteady when he's walking. Well, this seems like maybe a acute change in the patient's status. So you get a finger stick, it's fine. You call stroke code. CT head doesn't show any bleed. The labs aren't remarkable. Patient comes back from the stroke code or from the CT scan, and you're able to do a little bit more examination and history. And now you think it's actually Wernicke's. So you admit to medicine. That's what I did. So learning points here being you should know about everyone in your room, even these patients just waiting for discharge. When they're there 3 hours later, try to figure out why are they still there? Like, did the transportation sheet get lost? Are they actually still sick and they need things and they can't actually go? You should try to ambulate all of your patients. So if they're ambulating 3 days ago, they should be ambulating today. And if they're not, that needs to be addressed. And keep a very broad differential. I mean, this goes for every patient, but in this case, thinking stroke, metabolic, trauma. All right, my next example, CCT gets a note at 6:45 a.m., so just 15 minutes before rounds. Patients on BiPAP, they're 5 minutes away. When EMS comes in, they go, this is APE. He had crackles, he was in distress. We couldn't get a line, so we didn't give him any medications, but we put him on BiPAP. So the team tells you his initial vitals, his blood pressure was 120/75. He was a little bit tachycardic. He was awake and looking around. We couldn't really hear breath sounds that well over the BiPAP. He has some ascites, but no leg swelling. We ordered him for Lasix, nitro labs, chest x-ray. So the team tells you just follow up on the labs, the x-ray, just look at him and then admit him for APE. So I go in, he's tachypnic on the BiPAP. His blood pressure has gone down. It's 95/60. He's tachycardic. He's cachectic. He has large ascites. He has no leg swelling. I focus him and find a very large right pleural effusion and A lines, actually not a lot of B lines. It doesn't really look like APE after all. So I keep the BiPAP on. I weaned down the settings a little bit to try to help with the hypotension. I cancel the nitro and the Lasix. Chest X-ray confirms big pleural effusion. Labs showed decompensated cirrhosis and admitted to the floor for pleural effusion. So the learning points in this case, if the vitals don't really match the picture, kind of reconsider what you're thinking about. So in most instances, not every time, but in most instances, APE, those patients are going to be extremely hypertensive. And in this case, this patient wasn't really hypertensive even from the start. That's just something to kind of think about. Don't anchor on what EMS tells you. So EMS has way less resources than you have to make a diagnosis, right? They like them saying APE, maybe it is APE, but don't just go based off of that. And then, of course, after rounds, see this patient first, right? They're the most active. They've been here the least amount of time. They sound really sick. All right. I think second to last example, 85-year-old male with these comorbidities. He's found on the floor for an unknown amount of time by his neighbor. He has a headache, but otherwise nothing else. He's a little bit tacky. The team tells you he's ANO times 2. He had a hematoma. Breast sounds are clear. Belly wasn't tender. He just has like some scattered bruising to his arms and his legs. His labs show mild rhabdo with a CK of 8,000. He has a little bit of an AKI. We give him some fluids, and he's just pending all of his imaging and then admit to medicine for rhabdo and unsafe discharge. I go see him. He's ANO times 2. He looks pretty comfortable, but I pull up the gown and I look at his belly, and he has really significant bruising to his abdomen and his flank, in addition to the bruising that's on his extremities. He's moving all his extremities. He doesn't have any deficits. I don't think he had a stroke that led to his fall. So I ordered a pan scan based off of just all the findings and his age, and it showed rib fractures. Thankfully, no hemothorax or pneumothorax. CT showed a large subcapsular renal hematoma with a little bit of free fluid in the perirenal space. So I called trauma, and ultimately this patient went to the trauma service. So the reason I included this example is just to really belabor the point to like fully expose all of your patients. Sometimes, unfortunately, this means you might have to get the gown and do this yourself. But this is really important, especially in elderly patients who can't really give you history or maybe don't know about things that are on their body, to look for signs of trauma or even signs of infection. Make sure you examine all of your sign outs and just have a higher suspicion of injury in elderly patients with a ground level fall. All right, my last example is probably the one case that's really been in the back of my mind for a while. It's a 70-year-old female with a history of peripheral vascular disease, hypertension, diabetes, hyperlipidemia. She's coming in with acute on chronic bilateral lower extremity pain and hyperglycemia. She's a little bit tachycardic, but she's afebrile. Vitals are otherwise okay. The team tells me she looks like she's in pain. She had some venous stasis changes bilaterally. Couldn't really feel her pulses, but they were Dopplerable. Legs are a little bit colder than the rest of the body. Her labs show hyperglycemia, but no evidence of DKA. And the sign out is that she's pending bilateral CTAs of the legs and consider vascular consult based off of those findings. So I go see the patient right after rounds, and she's in a lot of pain. She can't even bear weight because of how painful the legs are. She does have venous stasis changes. She doesn't have any crepitus or blistering or erythema. Can't really feel her pulses. The compartments are really soft. But just based off of how I looked, I called vascular. Her CTA came back before vascular came down. It showed near complete occlusion of the distal SFA, but she has reconstitution bilaterally. There's no free air. There's no abscess. Vascular saw her, examined her. They're just requesting duplex to kind of assess the flow through the vessels. Many things happened in the shift, but the duplex was very much delayed. So I have to sign out to the next resident. So now this is the third sign out of this patient, which if you remember is a big red flag. Just to follow up the duplex results, follow up the vascular recommendations. But my contingency plan is even if vascular doesn't recommend anything, I think this patient still needs to come in for pain control. So vascular doesn't recommend anything, and the next resident admits to medicine for intractable pain and just covers her for cellulitis. While she's boarding in the ER, another provider walks by her and notices like bullae on her legs. So they call the medicine team and inform them. Fast forward the next day, she has neck fash. She goes to the OR and she codes on the table. I think there's a lot to learn from this case. I don't think anything was really done wrong. the most important thing that I took away is that skin and soft tissue infections will really humble you. And each person that looks at the patient is going to describe it differently. And these patients are on a really broad spectrum of illness, right? So ranging from cellulitis to abscess to neck fash, patients can be anywhere on that spectrum, any point in time, and they can rapidly move even just within one ED course. It's really important to reassess these patients. Even if consultants don't recommend these patients to be admitted or they're not going to do any intervention, you still decide their disposition. It's really important to document, right? Like I didn't write the IPN for this patient, but this patient's status changed and a lot happened within the shift. So it was really important to write all this stuff down. And then, of course, always be on really high alert of these patients that get signed out multiple times. At the minimum, they really need like reassessment. All right, my takeaways from today, signouts are just an inherently dangerous time. There's no one specific way to see them in a specific order. It kind of just depends on the room, but kind of develop your own style. Always be wary of the skin and soft tissue infections. Always fully examine your patients and reassess them, and just make sure you really keep your differential broad. These are my references. And then I just wanted to say thank you to a few people. To my parents, they're like the hardest working people I've met. Irfan, I think a lot of us kind of know about his story. He unexpectedly passed away this year. He's one of the surgery residents. We worked on SICU together and I learned so much. Not only was he like a really great surgeon, but I think medicine was his side hustle. And he just taught me to, like work isn't the most important thing. Dr. Khan, she's my second mom, always feeding me. We can have some of the like craziest shifts ever, but when Dr. Khan is there, I always know it's going to be okay. To my class, thank you. You guys are amazing. To my partner, Javier, who's just the food for my soul. And to Nivi for being my best friend. This was us in Hawaii, and it was like one of the best rotations and months we've had. Just some final thoughts. So after talking about signouts for 30 minutes, I hope you guys maybe take something away from that. But I don't think that's the most important thing in residency. I think, we can have a bigger impact on people. Our impact isn't just like prescribing antibiotics for pneumonia. I think the bigger impact we can have is actually just being kind to our patients and sitting there and taking that extra 5 minutes to really listen to them and like, why are they here today? Why aren't they here yesterday? Or why aren't they here like 5 days from now? And I think where we work is really overwhelming and it's a hard environment, especially when people are reaching out to you like every few minutes for food or water. But those patients are telling you things. It's really important that you listen and you get to go home at the end of the day, and these people don't. So just never forget the powerful position that you have and the vulnerable position that our patients have. And that's everything.